over to Dr. Gunnerson.
Thank you, Arvin. Thank you, everybody that took some time out on this Wednesday night to join Dr. Finney and myself. It's gonna be a relatively informal presentation. We're gonna, like the previous one for family medicine, we're gonna tell you a little bit about what emergency medicine and critical care medicine, and specifically, if you want some more questions later about how we merged these two specialties into how we have a fairly unique practice now. I've been out doing this for about 20 years, and Dr. Finney is one of my fellows. We both have a very similar background in our training, and we'll go into some of that a little bit later. But I was going to give you a perspective of someone who's been through all of the process that many of you are thinking about or in the process of going through now. The historical perspective is you got the old timer here. It's kind of like told you back what it was like in the past millennium. And then that's why I think it's really important with Dr. Finney on board on this call tonight to kind of bring in the more contemporary and what the current day situation that you're both or you're all are going to be facing as you kind of consider going down this pathway. So without further ado, let's kind of get started. Let's see. Start my show. A little technical difficulty here. I got two screens running. There we go. So our agenda tonight is we're going to review the specialties of emergency medicine and critical care. I'm going to tell you a typical day in my day of both emergency medicine and critical care. Dr. Finney is going to talk about from a fellow and even a resident, and quite frankly, even can relate back to more what a med student was like. We'll give you some pearls of wisdom, some things to consider about as you go through. Again, there's many steps, as you all well know, about how you go through this. We'll kind of give you some pearls that we, thought of, and again, of course, we'll have a lot more to discuss about. And then we've got some cool cases, some pictures and stuff that always are fun, especially for emergency medicine, to kind of show us what we've experienced. So just to start off with, this is just kind of a ripped definition of what emergency medicine is. I thought it was, fairly accurate. This is from one of our societies, American College of Emergency Physicians. It basically, I think most of you have either seen the shows, about the emergency department, or at least have been to one. Hopefully it wasn't too serious. But the ED is open 24/7, especially a level 1 trauma center like where we've been practicing. You're able to handle everything from, sprained ankles to the flu to, massive traumas to heart attacks to strokes, and everything in between. We deal with all the specialists, every specialist emergency presentation. So if you're an ophthalmologist, if you're a cardiologist, if you're a lung doctor, any of those, the emergency presentations of those specialties, they all come through the emergency department. So we really have to be trained in all of the specialties emergency conditions. Now, that doesn't mean we're experts in every one of these, but as far as the resuscitation, the stabilization of the patients, we are the specialists in that. And that's something that's why, it takes a 3 to now 4 year residency in order to be exposed to just the breadth of the amount of diseases that affect various parts of the body. So that's a good definition, I think, of emergency medicine. Critical care kind of takes that a little bit further. Again, critical care medicine, you can go into this pathway through very different base trainings. It is its own specialty. It's a standalone specialty, but you can also enter it through a base training in surgery. So you do a surgery residency, and then you do a fellowship in critical care. You can go through internal medicine. You can go through pediatrics. You can go through neurology, and then you can go through emergency medicine. And all of those base specialties allow you to then do extra years of critical care training. And critical care training really then hones into basically is what it sounds like. You take care of life-threatening conditions. We use cutting-edge monitoring and therapeutics and diagnostics. We have all of the different medications available to us that can alter your physiology in about any way you can dream up. We do try and practice as much evidence-based medicine as there is out there. However, a lot of the specialties change so fast that it's hard for evidence-based medicine to keep up. So that's where a really good understanding of physiology and pathophysiology and what type of indication the patient needs the ICU, whether it's after a big open heart surgery or if it's pneumonia. Understanding that physiology really well then allows you to improvise a little bit if your patient doesn't quite not meet the exact type of indication that the publications that guide our specialty, precisely. So you're able to, to think outside the box a lot and collaborate with a lot of other specialists to help come up with the ultimate treatment for your patients. Again, it's not as fast paced as emergency medicine. However, it's just as intense and deals with life and death, on a daily basis. And so that's the, kind of a gist of critical care for a specialty. And now this new thing that's kind of evolved really out of necessity, quite frankly, emergency critical care. Uh, Emergency critical care really, as like it sounds, it encompasses both specialties together. So unfortunately, we've had a problem in the United States on getting, and actually across the world, of hospital crowding. And this, is the same way here in the University of Michigan, as the same way as it is, all over, large centers and even, small medical centers in the country. Anytime you go to the ED, you're gonna realize that you're waiting a long time to be seen. So the problem for that, it's not just waiting in the waiting room to be seen, but it's also being admitted to the hospital. And even worse is if you're critically ill, you come in a major trauma, or you have a heart attack, or you have sepsis and you're in septic shock or pneumonia. And it may take you several hours, sometimes up to 12 to 24 hours to even make it to an ICU. And so you don't have the ability for those critical care specialists to come down to the ER routinely and manage your care. And so, again, out of necessity, we've been able to open up a pathway to where emergency medicine trained residents and would be now, physicians, or they'll be board certified physicians, can do a fellowship in critical care and then ultimately practice critical care while the patient is still in the emergency department. And so while they're waiting for 3, 4, 8, 6, 12 hours to be admitted to the ICU, we can then apply what we learned upstairs in the traditional ICU and do that downstairs immediately. So the patients are receiving critical care trained docs and nurses type of level care to actually start their therapy and to manage it for the first 12 hours. And many times we're able to reverse that disease to where they're able to be downgraded to go to the floor or even go home in some cases. So by front loading this critical care in the emergency department, we're able to really do a lot of good for our patients that fit this, in this little loop of, unfortunate, crowding situation that we're in. Here's just a whole bunch of writing stuff about me. I'll tell you a little bit more here in the next few pages. I'm just a simple old farm boy from Kansas. I grew up on a farm. There's our farm right there. It's been around for over 120 years now. First one in my family, in my immediate family, to graduate from college, and definitely the first one then to go on and escape the beautiful plains of Kansas and make it to, the beautiful inner city of Detroit, and do my residency and do my medical training. I after graduating from a small high school, which only had 50 students, and I didn't have any exposure really to anything in high school. I just thought I was interested in, medicine. It sounded like it was one of the hardest things I could do at the time. It was that or an astronaut, and there aren't too many astronauts at the time coming from Kansas. There were a lot more doctors. So I said, oh, that sounds very cool. And we had a family friend who was a medic in the war in Korea, and said some really cool things of some anatomy class I think I took. So then I went to just a small little local college. It was all pretty much paid for in scholarships. And then I got into med school at University of Kansas, a little bit bigger. Went from a small little town of 30,000 to Kansas City. And then from there, I ended up doing a residency in both internal medicine and emergency medicine at Henry Ford Hospital in downtown Detroit. And this was back in the 90s before, I don't know if anybody's familiar with the Detroit area, but it's actually very, very nice now. It's a lot of renovation and money has been done in the city. But back in the 90s when I was there, it was still a pretty rough and tumble area to practice. A great place to learn emergency medicine and critical care medicine. After being there for 5 years, I really, really enjoyed the ability to make a huge difference in these patients who are really sick in their lives and their trajectory by acting really early in their disease state. And so I went on and did 2 more years of fellowship at the University of Pittsburgh, UPMC. And that was probably one of the best 2 years of my clinical training. I really enjoyed it. After that, I went to Virginia Commonwealth University as a junior, as a young faculty. I ran the cardiac surgery ICU and actually became a division chief within the Department of Medicine or anesthesia. And then I also was an EM doc down in the ER. I was an ER doc doing both up in the ICU and then also down in the ER. After being at VCU for about 10 years, University of Michigan had a change in the chairman, and I had the opportunity to come back to the Michigan, Central Michigan area and practice both. There had also been a movement at the time of both emergency medicine and critical care coming together, which I was fortunate enough to be a part of on the board side. And so I had some inside knowledge on how to create, a fellowship. I had ran a unit already in ICU, and I was a practicing EM doc, and I was also doing a lot of shock research at the time. So University of Michigan gave me a call and said I wanted to move and start the country's first ICU in the emergency department. And so we did, and that's how I ended up here, and that's where I am today. And that was back in 2013. I've been here more than 10 years. So a typical day in the ED, it's not unlike what you probably see on TV. We don't, where I'm at, where I've been practicing mostly, we don't see pediatrics, but if you go into the community or even a smaller medical center, you probably will see pediatrics. But you basically see any type of patient that can walk in that door anytime. It's usually fast paced. There are some downtimes and some certain hours, and you kind of get used to these surges at different parts of the day and also different parts of the week. I've always been a part of an academic center, and at that time we've always had large teams, and they're comprised of residents, med students, fellows, and of course we have nurses, respiratory therapists, pharmacists. So it's very important to have good communication skills, and you work with a large team of very skilled and enthusiastic team members who want to do what's best for the patients. And especially in the ED, there's a lot of times that we're under-resourced and overworked and a lot of stress. And you can imagine families, coming in, or probably the worst days of their life. And, they're not, they're acting on a lot of emotion. And so we have to be able to train yourselves to keep a level head. And so you can think through of objectively what's going on and manage the patients, even when there's, 1,000 things that are, biting for your attention. One of the best things I think is the collaboration with all the specialties that we have. Again, I'm learning every day, and I've been doing this again pretty much every day in my life for the last 25 years or so. So I truly can say I see something new every day. Even now that I'm surprised. I'm not surprised at that when I'm surprised. Another great thing about this specialty is that you feel at the end of the day you really do make a difference. Now, you may not feel you're making a difference on a large scale, but you're making a difference in that on that patient level. And that's even with we're seeing again more things coming down that are going to be challenging for this specialty is the crowding, again the high stress that's associated with this, balancing as best you can your home life and your leisure as well as with your professional life. The usual shift, depending on where you go, anywhere from 8 to 12 hour shifts. But there are some places that are even, some of the lighter ERs that don't have as many patient volumes as a large center, and they even do 24-hour shifts. So it's fairly, variable on how long you're going to work. Now, to mix it up, the usual day in the ICU is a little bit more organized. If any of you have had any chance to go and round on in the hospital, you'll see, especially in the academic world, again, we have large teams that's directed by the attending physician, but there's usually 1 or 2 fellows at the most, and they're again in their highest level of training right before they're going to be an attending. You have residents, you have students, again, you have nurses, pharmacy, respiratory therapy, etc. And here we actually do more of a systematic approach. You're rounding on about 12 to 14 patients in a geographical ICU with all the monitors and ventilators and other types of devices to help keep the patients alive. You go over into great detail over every organ system. And so the resident or sometimes even the acute advanced practice providers like nurse practitioners or PAs, they'll present the patient head to toe about everything that's going on. And so we're able to then address all of the issues, even the small issues, we keep them from becoming large issues. So we're able to do that patient by patient, and that takes a little bit longer than what we're used to in the emergency department, just because you don't have the time like that down in the ED. We'll see the patients usually in the morning. Rounds start anywhere from 7 o'clock to 8, and they'll go, depending on how large the patient load is, they'll go until around 10:30 or 11, or sometimes they'll even spill over into the afternoon. And those are some long mornings if that happens. We make a plan for the day for all the patients. Sometimes that plan has to be expedited because they're not doing well. We plan out if we need to do any procedures or the patients need to go anywhere for any special type of imaging or other types of surgeries. And then we get ready for new patients, especially I work in a surgical-based ICU, and so we have surgeries that are scheduled, for the day. And so I've got to get the patients that are ready to go out. We get them ready to go out to the floor, and we get ready for the new patients after their operation to come in later in the afternoon. This is really rewarding because these patients, for the most part, are very sick. They have multi-organs involved. It's very complex. You think many steps ahead. The more you do this, you always are thinking, 2 or 3 moves ahead, what the patient's doing at that time and trying to anticipate what happens. Again, this is high risk, high reward. These patients are, again, it's life-threatening illness, life or limb-threatening, pretty much for the first 24 to, 48 hours that they're in the ICU, and sometimes even longer than that. You interact with many specialties, and you actually get quite close with some specialties that if you're in a unit that's specific for a certain type of population. I work in a cardiac surgery-based ICU, so I know all of the cardiac surgeons really well, all of the thoracic surgeons very well, all of the vascular surgeons very well. And so it's nice to have a professional relationship that, you can bounce things off of them, that's kind of outside of your expertise. You get to develop relationships with families of these patients, unlike the emergency department where you're only, exposed to them, for, the amount of time that you're on your shift, which is anywhere from 8 to 12 hours. And again, it's high stress. So it's, like down in the emergency department. Shifts now, it used to be when I started my practice, we were on 24/7 for a week at a time. And so I would start in the morning when I wanted to start, usually around 7. And then we would finish, go home after the end of the day about 6 or 7 at night. If there weren't really anything going on, I would actually leave and go home a little bit earlier. But you're on call all night around the clock, and if you needed to come in, you had to come in. It's getting more and more to shift work now, like the emergency department. So you work 12-hour shifts, 10 to 12-hour shifts. The nighttime is always the longer time, and that now really, the patients, they're not less critical at night than they are during the day, and so it keeps you busy throughout the night if that's the shift that you're on. I will go over some of the pearls from my perspective. I'll let Bronwyn talk about from her perspective. But some of the things that I've noticed over the last 20 some years, just as important as grades is your persistence. If you want to be a physician, you can do it. You're going to do it. You just don't give up. You're going to get a ton of roadblocks thrown at you. It's going to be hard. You're going to have a lot of failures, but if you really want to just keep on. You will get there. Persistence, it's just as important as grades, just as important as anything else. All right. And that's just one of the biggest things I can throw out there to you is just don't give up. You will find a way to get there. Undergraduate universities, I know we put a lot of emphasis in that when you're coming out of high school, not necessarily as important, as you might think, even if you want to go into one of these, really highly competitive, specialties, but just work on getting a well-rounded experience. You can even consider a non-traditional major. We've had very good, highly successful physicians, EM physicians, fellows, critical care fellows, who were music majors, who were engineering majors. They weren't the typical biology, chemistry, or human studies majors. So get your degree in what you are interested in, and follow your hobbies, develop your hobby, something that you really like. Don't give up on it. Just make sure you take enough classes to where you can do well on your medical college, admissions test or your MCAT test, because that is something objective that you will be, kind of graded and compared to other applicants. I also think getting some type of exposure to the medical system is more and more important. Just so it's such a unique ecosystem that's a lot different than what you would intuitively think it is. So, and this can't be replicated by any TV show. So hang out with, your family docs, if you're interested in, let them know you're interested. Go to see if you can shadow them. Go volunteer at the hospital or even get a job in the hospital. I took 5 years into college, and I took that last year. I worked in the hospital, both in the emergency department and up in the ICU. I was a ward clerk. Back then we had paper charts. I was stamping all of the paper stuff that goes in the chart, and I was looking at the monitors. I was, helping, put in the orders. So the more you can do, the more exposure you can get. I would highly recommend it. Other things, you can even get a part-time job as, paramedic, EMS training if you're interested in emergency medicine. That also is very, very valuable. Again, med school, it's long and it's really kind of an introduction to how physicians think, how they interact appropriately among other specialties, and other care providers within medicine, how to communicate, how to learn the talk, and so we can communicate well. But you're not going to be prepared at all when you come out of med school. Unfortunately, you're not going to get a chance to see all the different specialties, and it's very hard that we ask you to choose what you want to do the rest of your life only after a couple years. But that's just the way it's set up right now. So you may not be exposed to some of the niche specialties like, say, rheumatology or even, ophthalmology, unless you're able to get lucky and get in a rotation with that. And just like in undergrad, med school, that's also, now as long as you go to an accredited, good, well-established medical school, you're going to get, relatively the same training. There are going to be some nuances, the way that they do their curriculum, especially with patient exposure in those first 2 years. But that's less important than where you do your residency. Med school, again, is 4 years usually, and then residency is going to be anywhere from 3 to 5 years. It's very exhausting. But that's where you learn. I mean, that's really where you learn how to walk the walk. You're gonna learn how to do this. This is where you learn how to be a physician from a technical and medical knowledge standpoint. And then if you want to do a little bit extra, you can then work on a specialty. And that's where you do your fellowship, and that's what Dr. Finney is in right now. She's very intense focus on a specific area. That's anywhere from 1 to 3 years. And that's where you're really going to fine tune about diving into this type of knowledge. And then when you're done, you're considered an attending, and you have a choice of primary or community setting versus academic. And and that's just a whole nother life. That's more time than we have here tonight. So with that, I'll turn this over to Bronwyn. And Bronwyn, just tell me when to click and I'll advance it for you.
Sounds good. Hi guys, I'm Bronwyn. Nice to meet you, and thanks everybody for having me. Totally echo everything that Dr. Gunnerson said, and I'll share some of my perspective being a little bit closer to the process. I remember being in your shoes, and this all felt very long and intimidating. And now that I'm at least most of the way there to the finish line, I'm super happy I went on this journey. It's been a long ride, but each part of it just gets sweeter and sweeter when you get closer to the end. And I enjoyed it a lot along the way. So I am from Western New York, like in the Finger Lakes region, a small town in Corning. You can click next. I went to the University of Massachusetts. So yeah, I'm graduated about 10 years ago from college. I've been a traditional applicant, so I went straight from high school into undergrad and then straight to medical school. I kind of always thought I wanted to be a doctor. Didn't have a great approach to the path. My mom is a doctor, but obviously went into that a long time ago. And so I used my advising, I used kind of the internet, Google searches, and then somehow landed myself at SUNY Upstate. You can click next in Syracuse, New York. Again, I was a New York State resident during this whole point in time, so it was my local state school. I do echo what Dr. Gunnerson said. I went to state schools both for my undergrad and for medical school, and they provided, wonderful training and a great foundation for the knowledge base for my future residency and fellowship training. So I was there for 4 years. Again, didn't take a gap year. I applied during my third and fourth year of undergrad with the goal to just start this process whenever I was able. I do realize it's gotten harder and harder to get into medical school, and so there's plenty of people in my class that took gap years. I think when I started medical school, the oldest person was starting at age 40. And so just know that if your dreams or if the process is seeming long, it's never too late to pursue them. So after that, I can talk a little bit about how I chose emergency medicine. So I ended up at the University of Cincinnati in Cincinnati, Ohio, which was my kind of first time diving into the Midwest, which has been really awesome. Emergency medicine programs can be 3 or 4 years. It's just kind of the way they set up their curriculum. They are moving more to 4 years, though, just for the specialty is getting more and more complex. We're more far-reaching. I chose emergency medicine for a lot of reasons. I loved everything in medical school. I liked learning about the brain, the heart, the kidneys, and I just never knew when one organ was supposed to speak to me. I wanted to see everybody all the time. And I love, what Dr. Gunnerson said is that, we just take anyone that walks through the door. I'm sure some of you guys have seen The Pit, which is, I've been enjoying it quite a bit. I'd say it's obviously a bit faster paced than that. So I think if you stretched out one episode or one hour shift, that would be a pretty crazy day. But that kind of variety, doing one thing, getting pulled in another direction, figuring out that person, not having a plan for the day, it just keeps it so exciting. I never know what I'm going to see when I walk through the door. And I think also there's just, there's a lot of charted. I think, Dr. Gunnerson said one thing that I think, he struggles with, or we all struggle with, is like kind of how crowded and how overboarded the hospital is. Well, my one kind of gripe is with just how much we focus on looking in the computer with like the history of the patients. What have they been seen? Have they been seen for this before? What are the previous notes? What other hospitals have they been to? And something I love about working in the ER is that some of these patients come in anonymous because they're either unconscious or too sick to provide information. And so you are doing what I think is the purest form of medicine, which is treating the human being in front of you, using your physical exam skills, looking at them. If there is a story from the EMS providers, if there's a story from family, the vital signs on the monitors, the lab tests in real time as they come back. And it really feels like you are kind of on this investigation to at least stabilize them and get them to other care teams and other specialties. So emergency medicine, is great. It's fast paced. It's exciting. There's definitely the stress component to it, but it's something that you get more used to regulating with time. It makes you a strong leader of teams. You could have someone, you're in a room with, 30 people in the room that are all just trying to help the patient, and you're kind of the coach and the leader of that whole group. So, Dr. Gunnerson said it's a huge team-based specialty, and it allows us to work in so many different environments. So at the academic center, yeah, these huge teams. But I also did a job in residency where I was the only doctor in the hospital overnight. And so it's a small, 10-bed emergency department. And also there's no one inside watching the inpatients. And so there's such a wide variety of practice for whatever you're looking to make it. So the reason then, and you can click next, that I went into critical care. So I am at the University of Michigan. It's a 2-year program studying critical care, is because that I sometimes found myself wondering, well, what happens next? I did the best that I could for the patient with that first 4-6 hours of information. And, sometimes you just don't have all the pieces. And I wanted to know what was happening to them, a day, 2 days, 3 days, sometimes a week into their stay. I might have thought that they were having an infection and actually their heart was really weak, or, we decided to try this medication, and what was the response to that? And so critical care just provides what we kind of refer to as short-term continuity of care. I'm not seeing patients out in the clinic, week after week, but when I'm on the ICU for a fellow over the course of a month, I'm seeing those patients, as they're making their recovery, and hopefully for some people getting downgraded to like the general ward status, and then getting to go home to the hospital or going to rehab. And so, while emergency medicine gives me the exhilaration, the excitement, we call it the undifferentiated, the patient you don't have all the information about. Critical care is really just the tinkering, the making these micro movements that add up to making a huge change and improvement in the patient's future trajectory. And I guess just to chime in here on kind of what a typical day looks like as a trainee, the ER is pretty much the same for everyone. So if you're not the supervisory overseeing attending, you're just seeing whoever comes into your care area. So that could be a 99-year-old who fell down and broke their hip, and then in the next room you have somebody who has is taking a blood thinner and they're bleeding out of their nose, and they're just there's blood covering them and covering everything. And then in the room after that, somebody rolls in and they took too many of their sleeping medication, and so now you have to treat that. And your job is just to balance, what order am I going to see these patients in, and how am I going to check back in on them? It's like working at, the busiest restaurant as a server, and you just don't have unlimited tables, because at the end of the day, we can't fit our patients into 15-minute appointments. As soon as somebody sicker rolls into the door, we divide and we conquer, and we, come together to take care of them. And sometimes it makes us kind of stop what we were doing in the meantime. A typical day in the ICU, I echo a lot of what Dr. Gunnerson said. What changes for a fellow or someone that's a trainee is you're just more and more hands-on with the nuts and bolts. And so I'm working directly with the medical students. I'm working directly with the residents as we are, actually making sure the things we talked about on rounds are happening. So, growing over the course of the year, at first I'm kind of listening to rounds, starting to, understand a little bit more of the inpatient side of medicine. And then as I'm making sure if we said, hey, we're going to, call this cardiology team to take a look at our patient, or we need to put in that central line, we need to do this procedure, that I'm actually following through, that the things are happening, so that I can report back to the big boss, Dr. Gunnerson, and say, hey, we've actually checked off all of these boxes. So it's a little more methodical, slower approach. My first day ever in the ICU at the University of Michigan was with Dr. Gunnerson. So we've worked together quite a bit now. He's taught me a lot of what I've known. They're both fun. I think also a piece of this is just finding people that you vibe with. So, the further you get on, you start to learn a little bit about, we talk about like the culture, personality of different specialties. It's not to say you can't go into anything that, makes your heart content, but there comes a point where you're working, with teams of people, and you're working day in and day out with the same people. And we tend to find that a lot of people gravitate towards, people that have similar interests, like, similar personality types that, find comfort through their coworkers. So that's a little bit of my 2 cents on that. Guess I'm good for the next slide. Oh, okay. This is just a little bit more of, some of the typical things. So, on the top left, I was suiting up for a procedure. I was on the trauma service. So we rotate on, off service rotations during residency. And it was my hour 28. So sometimes we do work like 24, 28-hour shifts. And I had to put in a chest tube. It was my final call. At my residency, we flew in helicopters and like did some, EMS. And so we would go with a nurse and fly to a scene and pick up a patient, and then fly them back to the ER. And so it was kind of like, what's that pre-hospital medicine side look like? You could land on the highway, in a baseball field, go from hospital to hospital. On the right, and I can say this because it's been, published everywhere, but I was the one in the ER when Damar Hamlin came in Cincinnati. And what is it like to take care of, also just crowd control for so many people trying to figure out what was going on. But, sports injuries, there are people from my emergency department were on the field working with him, and giving him the, immediate care that he needs. And those are, the times that we're just so proud of our specialty. And then in the bottom left-hand corner is one of the ICU faculty. The cardiac surgeons who were actually practicing how to do heart surgery said, hey, do you guys want to just come like take a peek at the heart? We have an extra one for you to do in the cadaver lab. And so we went over there. We do not do heart surgery. We take care of the patients when they come to the ICU, but we went kind of looking at the valves and cutting around, and we just had a lot of fun doing that. So this was kind of, ER and ICU. And then on to the next side. So we talked about the family component, and that's what I really enjoy. So the patient on the top, consented to have his picture shared, but he had very severe end-stage lung disease, couldn't walk more than 15 feet without getting short of breath, and he got a lung transplant. And it wasn't, it was a bit of a rocky road, ended up having to get like a short to long-term breathing tube in the front of his neck called a tracheostomy. And I went over, and he had left our ICU, and I went over to visit him. And when I walked in, his face lit up, he glowed because I had been taking care of him, day in, day, night, through so many headaches, and for over a month. And he ended up, before he left the hospital, we were able to remove the trach. He was just back to breathing on his own with these fresh new lungs. And it was just such an exhilarating moment. And then the next two pictures kind of go hand in hand. You might recognize Dr. Gunnerson down there on the right, but wonder if you knew I was going to put this picture in there. But one of the things that we take care of in the ICU is something called ECMO, which is basically just a way to do kind of like, think about it kind of like how dialysis replaces your kidneys. Well, this can support your heart and lungs when they're too weak to do that. And so one of the things that's awesome at the University of Michigan is that when patients have, go and undergo a cardiac arrest or their heart stops, we have the ability to meet them down in the emergency department as the ICU team and help try to basically use this as a temporary support while we wait to see if their heart, can pick back up and if we can support them. And we had a whole bunch of doctors that work down in that, like, short-term emergency ICU unit, all come together. It's messy. There's a lot of stress. There's a lot going on, all to try to give the patient the best fighting chance that we can. There's obviously a lot of machines, a lot of beeping, a lot of tension. But these are people that we work, go through the tough things with day in and day out, kind of reflecting shortly after that happened. Definitely a lot of sweat added into that as well. So I think we're good for the next slide. And then this is just a couple of random pictures to express what our specialty looks like as well. I probably should have said trigger warning in case people were a little grossed out by this. I will say emergency medicine is a gross specialty. We definitely see a lot of different, body fluids, people going through just about anything. So on the top, we have someone with a, unfortunately devastating brain bleed. That's all of the white in there. It's not supposed to be there. You can kind of Google what a regular head CT looks like. So we take care of people with devastating neurologic injuries. The person down below came in impaled with a fence. And yes, the teaching is true. You should leave the fence or whatever the item is in them if they fall onto it. But I've seen someone with deer antlers stuck into them. I just couldn't find a photo for that. And so the team is just kind of all assessing them, figuring out what to do next. The top image is of a CT scanner. Someone went in to get a routine image and was having such a massive GI bleed that they just bled and basically hit the ceiling. The bottom right is a patient we took care of in the ICU, who had a very devastating form of pancreatitis and required so many abdominal surgeries that they had trouble closing their abdomen. So they were transferred over to the surgical ICU at the University of Michigan while we kind of cared for them, supported them until the surgeons were ultimately able to get, their abdomen closed. That's all of his intestines that are just swollen out there. And he ultimately ended up leaving the hospital and doing well. And then finally, we see all sorts of objects that aren't supposed to be there stuck into people, 4th of July, fireworks, things like that. And this was just a nail injury gone wrong on x-ray. So a series of that. So that's just a little bit of a flavor of what the ER and the ICU look like from my perspective and having gone through it in the shorter end. So my goal after this is to work at an academic hospital, teach medical students, teach residents, and then do 50% in the ICU. So taking care of probably the post-heart surgery patients and 50% down in the ER and have a nice mix of both of them.
Good. Thanks, Bronwyn. I have a couple more pictures. I know we're going to have some time for discussion, but uh, keeping online with just a couple more of the things that we do. Again, this is a little warning. Some of them could be a little graphic. I'm not sure they're going to get worse than the Bronwyn had up here, but uh, this this patient came in. Well, some of the best things if you do emergency medicine is you read the triage note, what the nurses write down, because they can be hysterically to the point, but completely. It's like trying to describe an elephant and you're pulling on his trunk versus his tail versus his leg. Not necessarily sure, but this patient who had neck cancer came in. This is one of the first patients I ever had when I first moved here, and I was in the lower acuity area and she came in for a wound check. Her husband thought she had an abscess or a pimple on the side of her neck, and he was getting ready to like pop it, but decided she said, "Well, let's go to the ER because it's getting pretty big." And so she came into the ER and she just went right by the nurses and triage, and they put her back in this again lower acuity area where I was. And I look at it and I get up closer and closer, and this little bubble was pulsating. And it's like, holy cow. And I look at that and I look at her chart and it's like, yeah, this is an aneurysm, a pseudoaneurysm, or I think an aneurysm of her carotid. And so I, at that time, trying to figure out if ENT was going to get in and get into that neck, or if interventional radiology, or if vascular surgery, or who was going to take care of this. Like, again, this was like the first week I was there. And so I'm trying to rally the troops and maintain that, make sure she doesn't get, hypertensive. So I'm giving her blood pressure medication. And everything was going well until one of the ear, nose, and throat residents came in and totally freaked her out. Her pressure went through the roof. And I told her husband, it's like if this thing pops, it's very easy because she had a very stiff neck like wood. It's very easy, just apply pressure and just call for help. Well, after that one resident left and said, we need to move up to the resuscitation bay and got everybody worked up, the next thing I heard was, help, help, help. And blood was just literally spurting across the room. So this is her after she ruptured. And this is the resident that I made hold pressure until they went to IR, because I was holding pressure as we moved up to the resuscitation bay. And so they went to IR. She had that coiled, had that all taken care of, and went home in about 4 days. So, that's it. That's exactly, the ER, it comes in saying it's like a pimple. And next thing you look at it and go, that's not a pimple. That's the carotid artery. And so that was my nice welcome. Here is a bottle rocket to the eyeball. And ophthalmologist, we did not do this, but ophthalmology, look at those tiny little sutures they put in. Look, it's actually even smaller than the eyelash. But then the patient came back a couple of days later, and this, complication ended up having pus. That's just like you'd see pus anywhere, that had now developed white cells that had developed in the anterior chamber of the eyeball. That's something else. It's nothing that we're going to do as an EM doc other than just make sure that, we're there to, make sure they get the care that they need. This is a patient who has a blood infection that's really caused him to this mottling appearance. That's your blood vessels really constricting to try and, to shunt all the blood into your core to keep your heart and your brain alive. Again, this patient was extremely sick, had a condition called septic shock, and it was on many different types of blood pressure medications, and unfortunately, he did not make it. But that's how, one of the severe forms of how this looks. This is a lady that had a B cell lymphoma that caused, massive, a lymphatic congestion in her arm. This was not infected. This was just necrotic tissue. Again, these are some of the things that we see. And this one was a chainsaw versus face. And I had some other ones to actually just you can show the eyeball, but this is, this young man was cutting wood and it kicked back as the chainsaw was still running and it hit him right there, in the face. Unbelievably, it had cut his entire eyelid on top in half, but did not even give him even what's called a corneal abrasion. It didn't even scratch the surface of his eye. The plastic surgery and ophthalmology spent many operations sewing all the skin back. But for him, this was all superficial, something like this. Um, this is a patient that has very bad diabetic feet, didn't even feel it. It's not painful at all because he had very poor circulation as well. This was a person who was standing on a ladder, and on the top right here, this is his ear, this is his neck, his chin's up there, and he had a long pole that touched the high voltage wire, which then went into his neck, and then here you can see high voltage as it exits his fingers. His hand is over here in the bottom left, and then his finger and his foot, or his toe and his foot over there on the other two pictures. Um, this was a traumatic amputation. A lady that was working in a factory up in the Upper Peninsula in Michigan got her arm caught in a machine with a belt, and it literally just ripped her arm right off. And of course, this was unsalvageable because even though the bone and the tissue was there, you're not going to be able to, replace the nerves, and so that hand wouldn't really been able to, that arm wouldn't be able to function. And again, she did really well. She went home in about 2 or 3 days. You can see the tourniquet that was applied. This was a LAR over here on the arm. This was a long transport, from up north. And that's it for the pictures. We got many, many more. Both of the specialties that we both do in the intensive care unit and also down in the emergency department. This is a perfect example of the severity of illness that we see. And the nice thing is we're able to either take care of this ourselves, or we know the people that can, and we stabilize them until the surgeons or the specialists can help fix them and get them back together again.
Your pictures even grossed me out a little bit, I'll be honest.
All right. Let me end sharing and we'll get back. I guess we'll open everything up to some questions now.
I guess I have a question. Do either of you regret going into emergency medicine, or do you think you made the right choice?
Good question, Olivia. I get to go to work when I'm doing my ER shifts, and I know that I'm going to be able to make an impact, and I make a difference. And every day there's going to be a new person, a new experience that's going to present with a fairly common disease process, but they're going to present uniquely. And I'm challenged with trying to figure out what's causing it and make a difference in the trajectory of that patient's course. So no, even though there's a lot of challenges in medicine, every specialty kind of has its pluses and minuses, and there's some pretty big frustrations in emergency medicine. But I'm not sorry that I made this choice, and I would make it again, especially with the critical care part of it.
Yeah, I don't regret it at all. I do know we are a high burnout specialty, which just means we deal with a lot of stress and it can really wear people out. I think some of the balance of having options, we didn't even have time to get into all the things you can do after the ER. You can specialize in like the wilderness, in ultrasound, in sports, in going to space if that's your sort of thing, and many more and then some. In education, there's a lot of ways to stay balanced. I also think with doing shift work, we do get called in the ICU, but from the ER standpoint, like when we're home, we're home. We've signed out to someone and we can kind of like relax and let the day fade away. Some of my classmates after residency, like one lives in Colorado, works 10 to 12 shifts a month and, hikes and spends time with her dogs. So there's definitely like a nice lifestyle component too. You can make it kind of as intense and busy as you want working at a busy academic center, or you can go, regain some of the life that you missed while you were doing all of the medical training. So no, I think if you do it for the right reasons and you try to, you can't save everyone. And I think that's one of the things you have to come to terms with. But when you realize that 100% of those patients that are critically ill would die if they didn't come in, and you focus on the ones that you can save, you start to really be thankful for the wins that you had each day.
Awesome. Thank you.
I think Alicia had her hands up, or Alicia.
Hi, my name is Alicia. Hi there, everybody. So I am undergrad pre-med, and I am extremely interested in research. And when I do become a doctor, I do want my main focus to be on groundbreaking research. I'm wondering, has undergrad research helped you in your career in medicine? And also, as an emergency doctor, if you were interested in continuing on with research, is there room for something like that with such a stressful schedule?
Yeah, that's a fantastic question, and I'm glad that you're thinking about doing this, Alicia. We don't see as many students now that are going into, research in medicine. There is definitely room for you. Uh, Undergrad research, again, as long as it's something you're very much interested in. If you really enjoy what you're doing, I 100% encourage you to take that down as far as you feel you need to go, whether that's a master's or a PhD, and then you can transition into, medicine, after that. Trying to, finish a program while in med school, it can be very, very hard. And so I would, as long as you still love it, I would finish it and then go into medicine. That is not unusual, especially at University of Michigan. We see a lot of our residents in various fields that have that exact same pathway. They come in as first year med students with their PhD already complete. So I would highly encourage you for that. In any field, emergency medicine, we definitely can use, depending on what type of research you're doing, you have a place. We have several of my faculty partners are doing bench type, research. They're doing basic science based research. I do a lot of clinical research and also working with, biomarkers and sepsis and septic shock and do clinical trials. And I've been funded my entire 20 years either through the NIH, the Department of Defense, or through industry. And there's definitely a role for that in critical illness and injury. And we have a great mark, here at Michigan, but they're all over the place. I'm not sure what field you'll end up in, but there is definitely a role for you and a place in medicine, and you definitely can make a difference going forward. You're going to have to. We're running out of things. We don't have as much, ways to treat these patients now. So keep it up.
Thank
Yeah,
you. I
I
really
would just say
appreciate that.
logistically, it's actually pretty easy within our field because we are shift work. And so as people increase their research base, they can work less shifts clinically. And so a lot of residents do it. People that do MD, PhDs will go into emergency medicine. And obviously, we have a broad spectrum of disease to choose from in your study area of research. So plenty of opportunity for that. I think Morgan next.
Hello, thank you for presenting. My question was, did you always have the stomach for dealing with that kind of gross stuff, or did you have to build up to it? And like, because I want to know if it's learnable to deal with that.
Yes, totally learnable. And you can wear like triple the masks and spread some toothpaste on to help with smell and all of that stuff too. We get over it. I think everybody always has something maybe that's a little touchy to them. I'm not crazy about burns or people like in pain from burns. And so, I just kind of realized that that's something that's tough for me. But I think once you start seeing things, you get a lot of, desensitization to it. And I think people that are queasy to start with can definitely still end up in our field.
I agree.
I think Kennedy, and then I'll also take a peek at the ones here that are popping.
Thank you. And again, thank you for elaborating you both on your experiences as physicians. My question was, what was one of the most valuable networking opportunities you had as an undergraduate that prepared you for med school?
Bronwyn, I'll let you start with this.
Sounds good. I guess you were. I think just trying to, touch base with anyone that has gone through it recently, as far as like either what, schools that they applied to, like how long they took to study for things, or what kind of, everyone is supposed to have, a niche or something they've done. Whereas, Dr. Gunnerson said you could be from like EMS to working as a certified nursing assistant to whether research was your angle. I did those summer research programs, like the SURF programs during my summers, and I feel like I met some other pre-med students there. Or if your school has like like an alumni network that can help set up with like people that have recently gone to medical school, or you're able to meet any residents. I think those can be helpful people because they've gone through it and the process is just continually changing. If those things are not available to you, there's sometimes like, medical forums such as this, or, I never made it to a conference until I was a resident, but I know I've heard it's getting more and more popular to do, even in undergrad years or in college years, that they have, some medical conferences that may, be applicable to you. So you can just start meeting people. Because I think the more stories and experiences you hear, the less intimidating the process is to go through. You can hear that, a rural farm boy from, who did not have anyone to go through this process with, made it all the way to such an impressive career. Or, someone like me who, has just made it through a lot of different stages, and had a different experience altogether. So I think as many different ways as you can meet people, will continue to help you out.
Yeah, I would just continue to add that, depending on what year you are in undergrad and what you have available, small university, large university, just, ask some of the local doctors, for the most part, they're all very open to helping young, aspiring med students out of what it's like. And then, if you want to take an extra time to, work in a hospital environment or work in a, clinic or EMS or some type of place to get an idea of what you're getting into, that goes a long way, not only for yourself and your own personal development, professional development of kind of what to expect, but also it shows that you're serious and you know what you're getting into to, the application committee, of the med school that you're applying to.
I think we had Mira next.
Hi, I'm Mira. I'm an undergrad at Michigan, and thank you again for your time today. It was really interesting to listen to your topic on emergency medicine, as it's an interest of mine. My question is, what was a time in your career, whether that be medicine, medical school, residency, fellowship, now that you've had like an adverse event, and how did you overcome that? And I know that like emergency medicine itself like is not the easiest, so I'm just interested to hear your thoughts.
I think I can actually share the recent story that I shared of Dr. Gunnerson and I going down to the emergency department. I had kind of the pictures with the blood all over the floor, for a young patient that I was actually, 10 years out from getting a heart transplant. So she had a lot of, congenital issues. And, really unfortunate story of just, having to leave the hospital a couple of days in advance to go back to work. And then she was Ubering herself back to the hospital when her heart stopped in the Uber. And she came into the emergency department. And so, while we do put people on that support device called ECMO, when their heart stops and we're trying to get their blood circulating, we do it all the time in the ICU, for patients undergoing heart surgery. It's a little bit different when you're doing it and you're under a crunch and the, patient's heart is not currently beating. And it was a very high stress situation in which we had a lot of people coming together, trying to find all of the equipment downstairs. There were definitely some complications with just getting the, actual like big IVs that go into the artery and in the vein to be in the right orientation and to get them in, stuck in all the way. We had the cardiac surgeon coming in from home, and he's in a pair of shorts and boat shoes and a polo shirt trying to put on a gown to figure this all out. And we both ran down from the ICU because we were up in the ICU trying to figure out how we could help. And no, I don't think due to the care that we provided necessarily, but due to, a number of uphill battles from being out in the world, having your heart stop in an Uber, technical challenges related to this. The patient ultimately had a devastating brain injury from not having enough oxygen during the time that her heart stopped. And, I don't know that we could have done anything differently to save her with how the cards were stacked. But it was a recent, outcome that I live with that was, an adverse outcome from something I could have been a part of or something that could have happened anyway. And I'll never really know the difference. And I think what we did is we debriefed as a team. We talked and supported each other. Dr. Gunnerson checked in on me on the coming days. We checked in with the team downstairs with the ER nurses because we are all impacted by this and going through it. And I think just realizing that everything we can learn from this to help the next patient, because, that's just one patient, one time. And we're always working to better ourselves and learn something new every day is at least how I cope with that and recover from that and know that, this, sacrifice or this, injury that happened was not in isolation, and it can help someone else in the future.
Yeah, I think it's different for everybody. Over the years, I've had several great mentors who've helped me, especially for these, types of patients, that Ronald's talking about. Before you learn from some of these outcomes that aren't, exactly what you'd want them to be, so you can be better the next time that they come around. And that's a long process. It's a lifelong process. It's a career long process. And that's not to say, you're not moved and, feel empathy for the family and the patient and what they've been through. But, just with empathy alone, and if you don't learn anything other than that from it, then I think that would be, kind of a, I wouldn't, waste is kind of a strong word, but it'd be a waste of an opportunity to get better from it. So I think it's our job, our duty as the type of physicians that we are, that yes, being empathetic with the family and being with the patient and what they're going through is a big part of what we do, but we have to learn what we did right and what we did that we could improve upon. So the next time that this happens, that we're prepared, to maybe do it a little bit differently and a little bit better. And then we're going to learn from that one as well. And so I learned that, or started practicing that from a very early stage in my career. I probably had more of a traumatic experience that stays with me as my first year of med school. Um, During, it was such a big change from undergraduate until med school, and I almost got, flunked out and kicked out, and I was just a number, and nobody really cared, quite frankly. I didn't have any, this is a long time ago, but I was just a number, and if I was gone, then they'd have somebody else take my spot next year. That's literally, you're on your own, and that's why I say just be persistent. You'll get through this. You'll end up beating your goals if you're persistent with it.
I've been tackling some in the chat, but I think one week that we might want to elaborate on more if you want to go first while I finish up is just talking about work-life balance through medical school. And I guess you can comment on your life now, Dr. Gunnerson, even up until today, and just kind of like, putting your life on hold, making a lot of sacrifices and like not losing yourself in the process.
Yeah, as Bronwyn probably remembers, I tell all my residents and fellows, there's no such thing as work-life balance. It does not exist. You make sacrifices. It's going to be imbalanced, and that is okay. That is completely okay. There's no balance. There's no equal balance between this. Some days you're going to put more emphasis on your family, and that's perfectly okay. And some days you're going to put more emphasis on your work, and that's okay. That's what you chose to do. So there's no real balance. But make your decision, make your choices, and live with them, knowing that they're perfectly fine. Don't be hard on yourself. We're very bad, very poor about having compassion towards ourselves. A lot of times, especially in medicine, it goes right along with having imposter syndrome. So those are two, psychological disorders that we're all, subject to at one stage in our career or another. But just know there's no such thing as work-life balance. There's going to be imbalance, and that's perfectly okay. Do your best, make your choices, and modify them as you go along if you need to.
Yeah, I totally agree. Medical school is obviously tough. Residency is worse, and then fellowship gets a bit better. The further you get out, and hopefully attending hood is even better from there, but I'll let you know when I get there. I think just, starting to really realize what brings you energy. Are you, a people person who wants to, go out to dinner after a long day? Are you someone that wants to curl up in bed with a book and talk to no one, and take a long nap? I think just realizing what energizes you and trying to have, good people around at every stage of training that are in the medical field so they understand what's going on. I'm now in my 10th year of long distance with my now husband, who's finishing up MD PhD school. So that's something, we could always get into at a later point, who, we did an MD and a PhD at the same point in time. We've both been in the medical training path, but we both understand what the other person is going through. So I think that has helped quite a bit. And having, while my college friends or people that didn't go into this path may not always understand, oh, Bronwyn's just, at work again, or she's studying again, making friends undergrad pre-meds or having friends in medical school, having, strong friends in residency. The further you get along, the more people you find that are also probably like you from a personality standpoint, I think helps quite a bit. and just realizing that you just have to take it day by day at a time and not think about, the 5-year journey ahead or the 10-year journey, because it's a long road. So I think if you just put your head down and think about, today, or sometimes I don't even know, what I'm going to eat for dinner tonight when I'm, in the ICU, but I'm just trying to do with the information I have at that point in time. Because you can do it. And I think you can, travel and do the things you want to do when you have some free time, and you can, put your head down for a week or two, and grind in the hospital or in the library while you're still studying. And that a lot of us, hopefully you meet a lot of happy physicians through this program and through the work everyone's done to set this up, because, it's been a long road. And, I think we're all still, hopefully most of us are still smiling and happy that we did it. So that's what I have to say.
Yeah, something that always makes it easier for me is that, we're very, very privileged to be trained and put in a position to where, we can really help people that come in very vulnerable, and the trust that they place in us. They don't choose us. It's not like, we're their dermatologist or their plastic surgeon. They don't come, to the emergency department or even the ICU because of us. We don't have that relationship, but I guarantee you, they're having, if not the worst day of their life, one of the closest worst days of their life, when they have to see us in one of the capacities or more that I showed some pictures of. And so to be in that position to where we can make an impactful positive meaning in their life and their families' lives, and even on those ones that are unfortunate and they don't make it, if we're able to be with their family and to provide some comfort with their family and the patient as they pass on, that's also very, very helpful. And again, for us to be trained in a way to where we're in this position every day we go to work, it really is a privilege. And that, I think, that really just helps those sacrifices, make it worthwhile, because then you realize that, that was not much to sacrifice to be with this dying patient and help their last few, minutes on earth, respectful and comfortable along with their family members. And so those types of experiences happen all the time in our profession. And it really kind of puts everything, I think, in more perspective.
Well, I don't see any more questions unless we have any last ones. But I think that will be it for tonight. Thank you so much, Dr. Gunnerson and Dr. Finney, for hopping on. And thank you, everyone, for joining. Roy, I'll pass it on to you to sort of talk about the attendance. But yeah, thank you all so much.
Yeah, please feel free to fill out the attendance form that Arvin dropped in at the start of the meeting. We would love to hear your responses and get to know like how we can continue to accommodate you guys more in future sessions. So yeah, thank you guys for attending. Yep.
Thanks again, Arvin. Thanks, Roy. And thanks everybody for showing up for this.
Thank you so
Appreciate it.
much.